Welcome, everybody. Thank you for joining us today for today's webinar, New Ideas for Substance Use Condition Treatment. Could Psychedelics Help? My name is Susanna Baruch. I'm the Executive Director of the Petrie-Flom Center for Health Law Policy, Biotechnology, and Bioethics at Harvard Law School. And this event is part of Petrie-Flom's project on psychedelics law and regulation and the project on law and applied neuroscience, which is an ongoing wonderful collaboration with our colleagues at the Center for Law, Brain, and Behavior at Mass General Hospital. Our discussion today will include a range of perspectives on psychedelic treatments for substance use conditions, looking at the research, potential benefits and risks, policy and legal approaches, and societal implications. We are fortunate enough to be featuring two of our senior fellows from the Petrie-Flom Center and two external experts. A couple of housekeeping matters. Nothing you hear today should be considered legal advice or medical advice. We will have the chat turned off for viewers, but you can submit questions at any time using the Q&A function found in the meeting controls at the bottom of your screen. You can join the conversation or submit questions via Twitter or now X. We will share a fully captioned event video in a couple of weeks. And if you have any technical issues, feel free to email us at petrie-flom@law.harvard.edu, and we'll try to help. I also want to mention, if you're interested in our upcoming events, please check out our website. And a special note, we currently have applications open for our boot camp on the law and policy of psychedelics. Applications close on March 31st. So now I get the privilege of introducing our moderator, Stephanie Tabashnik, who is a forensic psychologist and attorney who, as I mentioned, is a senior fellow in law and applied neuroscience, part of our collaboration with the Center for Law, Brain, and Behavior. Stephanie is known for her important work and writing at the intersection of substance use policy and family law in particular. Her practice areas include substance use, forensic psychological assessment, child custody, and criminal forensic evaluations. I will turn it over to Stephanie and let her introduce the rest of today's panel.
Thank you. I am excited to be here, and we're going to be talking about psychedelics as a treatment for substance use disorder. I think you will see that this panel has a lot of knowledge, and we may have some vigorous debate. So we're looking forward to learning more, and you can put your questions in the chat, and we will get to them as time allows. So I am joined here by Mason Marks. He is a physician, an attorney, and a visiting professor of law at Harvard Law School. He's a professor at Florida State University College of Law, and he is the senior fellow and project lead of the Project on Psychedelics Law and Regulation at POPLAR at Petrie-Flom. And he's also a visiting professor at Yale Law School's Information Society Project. Deborah Mash is a professor emeritus at University of Miami Miller School of Medicine, the departments of Neurology and Pharmacology, and she's the CEO and founder of DemeRx, which advances non-addicting medicines for treatments of addiction, and she's an expert in ibogaine, which is an African hallucinogen. She also did a fellowship in neurology at Beth Israel Hospital, Harvard Medical School. Mark Guckel is a recovery coach. He's a certified psychospiritual integration coach and national speaker and educator on the pathways of psychedelic-assisted recovery. He is in long-term recovery of over 30 years from crack cocaine, heroin, and other substances with the help of ibogaine, ayahuasca, and psilocybin. So I'm going to start us off by just providing a sort of brief overview of substance use disorder and this as a condition, and then also some of the psychedelics that we're going to be talking about today. And then I'm going to kick it off to Mason, who's going to talk about the legal policy side of this. So this is substance use disorder is an incredibly prevalent condition, and around 17% of people in the US have met criteria for a substance use disorder in the past year. And we know that there are incredible treatment shortages. So most people who want to access a therapist or an addiction medicine psychiatrist are not able, and less than 10% of people in the US actually access substance use treatment. So we have a treatment shortage. We also know that a lot of the treatments that we have are not particularly effective. Some of the treatments that we have available that are, I'll call the conventional treatments of substance use disorder, are behavioral therapies. So contingency management, motivational interviewing, medication compliance therapy. And then we also have a number of medication treatments that some of which have much, I would say, better efficacy. So for opioid use disorder, methadone and buprenorphine, naltrexone, and then for other conditions like alcohol use disorder and cocaine use disorder, disulfiram, modafinil, and dronabinol, which is for cannabis use disorder. So I want to be clear that none of the information shared today is medical advice or legal advice, and that psychedelic therapy is not a replacement for medication treatments like methadone for opioid use disorder. All of our panelists will also agree that these are not first-line treatments. So if someone has a substance use disorder and it's early, no one is recommending or suggesting that you should go out and try these psychedelics first as a method of treatment. So in terms of just the classes of psychedelic treatments for substance use disorder, these are the main substances that we'll be talking about. We'll be mostly focusing on ibogaine, iboga, and psilocybin, but we may also touch on other substances or other psychedelic treatments like MDMA and LSD. So we have the classic psychedelics, and then we have the sort of non-classic psychedelics, and all of these have been studied to varying degrees. And we'll be talking about some of that research as we go through the panel, and also people's experiences with these psychedelic treatments. So I'm going to kick this off to Mason Marks, and he's going to talk a little bit about the legal and policy landscape. And then we will go to Deborah Mash, and then Mark, and then we'll have a vigorous discussion that I will moderate. Thank you.
Thank you so much, Stephanie, and thanks to Susanna, the Petrie-Flom staff, and the staff of the Center for Law, Brain, and Behavior for making this possible. I'm going to speak briefly about some legal and ethical issues, and I will focus primarily on psilocybin and ibogaine, which I think are the psychedelics for which there is the most enthusiasm for use in the context of treating substance use conditions. I think there are other psychedelics that have potential, including LSD, but right now this seems to be where a lot of the excitement and research is. Psilocybin is produced by certain fungi and around the world, and ibogaine is produced by a forest-dwelling shrub called iboga that's native to Central West Africa. And psilocybin mushrooms have a long history of ceremonial use by the Mazatec people and other communities of southern Mexico. I think it's less frequently acknowledged, though, that ibogaine is used by communities in West Central Africa, primarily in Gabon, but also in surrounding countries such as Cameroon. And the Babongo people, who are some of the earliest inhabitants of this region, are believed to have discovered iboga and its psychoactive properties, and they're likely originators of a spiritual practice called bowiti that other communities have adopted, like the Bantu populations in the region, who have borrowed and modified these practices. So there's a diversity of people that use iboga in Africa, and their practices are also quite diverse. Here in the United States, psilocybin and ibogaine are federally illegal outside of narrow circumstances from medical research. They're Schedule I drugs under the Federal Controlled Substances Act, which means that according to Congress, they have no currently accepted medical use and a high potential for abuse. Now, while there's significant ongoing research to investigate the use of psilocybin for treatment-resistant depression, there isn't as much research for using psilocybin in the context of addiction. There's some early research on its use in tobacco and alcohol use, which for obvious reasons could be very, very important and have a significant public health impact, because alcohol and tobacco are associated with significant mortality in the United States. I think many people don't realize that cigarettes are still linked to nearly 500,000 deaths each year in the United States. Unlike psilocybin, there's no clinical ibogaine research in the US right now, though, and that's likely due, at least in part, to the risk of cardiovascular adverse events, because ibogaine has been linked to heart attacks and some deaths. So ibogaine research occurs outside the United States, for instance, in Mexico, where there's also a significant ibogaine tourism industry. But despite the federal illegality of psilocybin and ibogaine, many US states and cities are changing their laws regarding these substances. So about 24 cities across the US have decriminalized these substances to some extent. And Oregon last year opened a state regulated program for supervised administration of psilocybin. So state licensed individuals called facilitators can administer psilocybin in state licensed facilities called psilocybin service centers. Legally, Oregon psilocybin cannot be advertised or used as a treatment for addiction or for any other health condition for that matter, but there are some companies that advertise their services for that purpose, or at least imply that their services could be used to help treat addiction. But next year, Colorado will open a program that's similar to Oregon's in some ways, but Colorado will likely allow psilocybin to be advertised and used as a medical treatment by licensed healthcare professionals. And there is the potential that regulators will allow ibogaine to be used as a treatment for addiction under medical supervision, starting as early as next year. But in light of the federal illegality of psilocybin and ibogaine, there are many unresolved legal questions, some challenging legal questions, and questions of potential liability as well for licensed healthcare professionals who choose to get involved in these programs. Before I wrap up, I want to mention some efforts in various states to utilize opioid litigation settlement funds to promote ibogaine research. So there were some opioid lawsuits filed against several companies, including Purdue Pharma, which produced over $50 billion in settlement funds distributed to the states. And there have been some efforts in Kentucky to utilize those settlement funds for ibogaine research. That failed last year, and that effort has now shifted to Ohio, where it's under consideration. And the intended purpose of these settlement funds is to remediate the harms of opioid addiction. So one might ask whether ibogaine research is the best use of these funds, because it could take many years or even a decade to produce viable, usable treatments, whereas there are medication-assisted treatments that are technically available, but in many parts of Ohio, such as rural areas, people don't have access or they can't afford them. So one might ask whether it might make more sense to utilize those funds to increase access to people for existing treatments. And then finally, I think given the longstanding pioneering use of these psychedelics by indigenous communities in Mexico and Africa, we have to ask, what kind of engagement and compensation are these communities due for their discovery of these substances, which are used locally, natively, for addiction, as well as for spiritual purposes. So I think that's a very important aspect of this conversation. Thanks so much.
Thank you, Mason. That was really interesting. So now we'll turn it over to Deborah, who's going to talk about research involving psychedelics. Thank you.
Thank you, Stephanie. And thank you, Mason, for framing the discussion. I'm going to go fast with these remarks. I'm a neuroscientist, and I've been working on ibogaine from 1992 to the present. I first learned about ibogaine, which you've heard is an indole alkaloid isolated from the roots of Tabernanthe iboga, which grows in the region of Gabon and Cameroon. But what you may not know is that ibogaine was actually sold in pharmacies in France for 20 years in low-dose tablets under the trade name of Lamberine. And it was sold as an antidepressant. So it has a very long ethnobotany, ethnopharmacology behind it. In 1992, I learned about an underground railroad of so-called addicts. We don't like to use that word anymore, but addicts helping addicts. It was called the International Coalition of Addicts Help, which was treating people with ibogaine in the Netherlands. There was a psychiatrist himself, someone who had done pioneering research with LSD, with Holocaust survivors, and he was working together with this group. And in Miami, we were at the height of the cocaine epidemic, and this was I had just started as a a new faculty member at the University of Miami, and we had all of the problems being in the front end loading of the cocaine epidemic in my community. And I had also been working with medical examiners and first responders. And in desperation, I got on an airplane and I went to Amsterdam, and I saw with my own eyes the ability of ibogaine, which, by the way, was not administered in a safe environment. It wasn't a medical unit. It wasn't a detox unit. But I saw patients exhibit a remarkable recovery for a longstanding heroin abuse, cocaine dependency disorder, and a young man who was on methadone maintenance, who remarkably had no withdrawals, no cravings, and it put their desire to go out and use drugs in remission. So it was a very powerful addiction interrupter. Today, as we heard from Mason, there is a large network. We estimate over 30 ibogaine clinics that are operating outside the United States, some more medically regulated by themselves, but these are operating in the gray zone, what we call the gray zone of medical therapy. We also know that patients who are sometimes desperate to seek ibogaine and buy it through the internet or to get it, for some other online distributorship, which is not a good idea because, again, as Dr. Marks said, people have gotten into trouble with ibogaine because indeed it has what we call a narrow therapeutic to toxic window. So you have to be very careful. Also, it's a complex pharmacokinetics. It has the potential. What that means is it has the potential for drug-drug interactions. So there's demonstrated efficacy. There's a long-term use, underground use in unregulated medical settings. But is there a regulatory path for ibogaine approval? And that's where I got involved with my own company and brought ibogaine at the height of the opioid epidemic back in front of the regulatory agencies, and have entered into discussions both about ibogaine itself and the active metabolite of ibogaine, noribogaine. So this is something for us to consider. We heard about the interest in ibogaine and the opioid settlement funds in Kentucky, and again, new information and possibilities in the state of Ohio. The only way that we will be successful with this is to get in front of the FDA and to work with the FDA, who has been very, very responsive for many of the psychedelics. We know that many of them have gotten what is called breakthrough designation. I believe there is a regulatory path forward for ibogaine if we can get past the safety hurdle, which I believe our data suggests we will. If it's given under medical monitor, it can be given safely. And with that, we could advance to an efficacy trial, a phase 2 efficacy trial, and that would open the door for patients' right to try or compassionate use on a named patient basis. Thank you.
Thank you, Deborah. That was really interesting. So now we're going to turn it over to Mark, who is a recovery coach, and we're going to hear more about his experience doing psychedelic and psychospiritual integration, coaching, and his own lived experience. Thank you, Mark.
Thank you very much. And thank you to the Petrie-Flom Center, as well as to the Center for Law, Brain, and Behavior for such a great event. I'm both honored and humbled to be here. My name is Mark Guckel. I'm the founder of EntheoRecovery Solutions. But more importantly, I'm also a person who is in recovery because of the help that psychedelic medicines gave me. Now, I have a story to share with you, but what I'd like you to know is that there are many other people that have just as remarkable stories. And as the years progress, there will be a lot more people who share their experience and stories of redemption very much like mine. And it's pretty much credited to the help that psychedelic medicines give people during the recovery process. I struggled with crack addiction for the better part of my life. I picked up while I was in high school in 1989, and pretty much after that, my life ran pretty much like I was a slave to the drug. I faced a lot of unusual consequences. I caused people harm. I did terrible things like steal from my mom, from my family. Yet I always believed that recovery was possible because other members of my family had gotten their lives together with the help of 12-step programs. So that's what I always subscribed to. In 2016, my father died, and I inherited $2.6 million while I was in recovery. I did very well for a little while, but within a few months, I was sequestered in my bathroom, smoking as much as $3,000 worth of crack cocaine every other day. Now, I don't have any pictures that I would share of this with you, but I'd like you to imagine how sick that I was. If you can think of someone who was close to death that was unable to stop using, that was me. And I'm very blessed to be able to tell you this story because there are a lot of people who aren't as fortunate. Now, desperate and dying in my bathroom, I found a video. I found a video on YouTube that discussed ayahuasca addiction and trauma. And it was an interview with Gabor Mate, who at that point in time I was unfamiliar with, but I was so sick that I was willing to try absolutely anything. And while it took me a few months to work up the courage and be able to get to some of these medicines, I ended up working with ibogaine with a practitioner in Florida. And then after that, I continued my path of self-discovery with a handful of ayahuasca ceremonies. Now, that is really where the story ends, unfortunately, because after 4 months, I fell back into old behaviors and I ended up sequestered back in the same bathroom doing the same thing again, yet with a different level of consciousness, knowing that there was a way out and that I should have never been back there in the first place. To wrap things up, once I began working with psychedelic medicines, all of the efforts that I put in the years past suddenly made sense. All of the step work that I did, somehow it felt like a jigsaw puzzle with pieces missing. Yet after I worked with psychedelic medicines, everything seemed to fill in. And I can say that while it helped me to stop using substances, and I'd like to reflect that these aren't like a cure. These are catalysts, they're sacraments, they're medicines, they're tools, they're amplifiers and revealers that show us the deepest, darkest parts of ourselves and things that we need to address so that we can become better human beings. But what I can say along with this is the healing process, it takes a while. And it's been something that I've certainly prided myself on, and I'm blessed to feel like I've broken some generational traits that have plagued my family for many years. Now, today, I have very close to 42 months clean that I've been away from any harmful substances. And I haven't sat with any psychedelic medicines in almost 5 months now. I've been feeling really good, and I've been taking a lot of time to integrate all of the past experiences that I've had. Professionally, I like to share my story. I like to carry my message. I think that it's super important that people are given proper information, education about psychedelics with one hope, that people understand that there's less and that so people feel as though this is just one of many pathways, right? There are many other treatment modalities that are out there, from people going to regular treatment to medication-assisted recovery to other holistic health modalities that help them to live better lives. So with that being said, I'm very grateful to be here today. Thank you.
Thank you, Mark. That was really helpful. So I'm going to have everyone come on video and we're going to have a discussion. And please put any questions in the chat and we will have our experts answer them. So first I had a question for Mark. Mark, you talked about treatment and then psychedelic treatments. And I'm just curious, in terms of medications like Suboxone and methadone, and are people typically staying on those medications and then trying psychedelics or using both, or what has been your experience as a recovery coach? And I think you're muted.
Every time that I do a presentation like this or get onto a webinar, invariably I have people that reach out to me that are very sick, that many times have been placed onto medication-assisted recovery, where they've been taking Suboxone for many years, and they're trying to break free of that. Psychedelics, medicines in general, don't seem to be the first line right now. They seem to be things that people go to when they're disillusioned, disenchanted with the current treatment protocols and with providers' unwillingness or inability to help them to taper off the medication so that they can live self-directed lives.
Thank you, Mark. And one thing I'll say as a therapist who works with people who have substance use disorder is that there's no one-size-fits-all approach, and different things work for different people. We do know that the standard of care for opioid use disorder is medication treatments like Suboxone and methadone. But we do have a question from the audience, and the question is from Susan. And she says, why are psychedelics considered a last resort? Why would we not attempt to treat the root cause first with these medications that have potentially more impact than anything we are currently using? And I'll give that question to Deborah.
It's a fundamental question, and it's an important one. It deals with the standard of care. Without evidence-based research, we don't have regulatory approval, we don't have a label. That's the way society, that's the way we work. That's how medications are given. That's how payers decide a price for a product. We have a void right now in terms of the lack of evidence-based research. Do I think that we should allow patients the choice to choose between medication-assisted therapies, as explained by Stephanie, Suboxone or methadone, or following detox naltrexone versus a psychedelic? I think most practitioners would absolutely not encourage psychedelic use. However, that's why we're here. That's why we're on this call today, is to try to think outside the box and to hope that we can gain more funding for the research, number one, which has been my battle cry for over 30 years. Let's fund the research and get the evidence, but also to work with the providers and the payers.
Mm-hmm. And Deborah, what I'm also hearing is it's not necessarily medication treatments that are more conventional, like Suboxone or psychedelics, but it's both. Yes. And there can be an interplay there. Mason, I see your hand up. I'd love to hear from you.
Yeah, I was just going to quickly say that I think that the reality is that if psychedelics become FDA approved, they will be quite expensive for quite some time. There are estimates that MDMA might cost $15,000 or so for one round of treatment, and I think the estimates in Australia through their sort of pilot program is in the 20 to 30,000 range, so it's even higher. And so for that reason alone, they're unlikely to be first-line treatments, regardless of scientific efficacy. It'd be far more likely that in order to be reimbursed, if reimbursement is even offered, and that may be challenging, most likely people will be required to go through other therapies initially that either are more established or are less expensive.
Okay. And are there certain people that should not be trying or using some of these psychedelics? Like, it sounds like there's a lot of people who could benefit potentially from psychedelic treatments, but what about people who maybe should avoid different psychedelics? Deborah, can you talk about that?
Definitely. Again, what we worry about here is that someone can do harm, and those would be people who may have an underlying psychiatric comorbidity like schizophrenia, they would not be a good match for this. And we know that some of our schizophrenic patients will self-medicate with opioids and alcohol. So that's an example there. Also, some patients with a diagnosis of bipolar disorder may also be at risk for psychiatric worsening of psychotic features of the disorder. So these are the things, again, why we want these molecules to be used in a medical way by qualified clinicians, and again, working with integration and therapists who understand these types of therapies and how they can work best. Keep in mind, too, that when these drugs get approved, they will likely be approved under what is called a REMS. And a REMS is a risk evaluation and mitigation strategy, which will inform clinicians, doctors, and therapists on limitations of use and how to not put patients in harm's way.
Okay, thank you. We have a ton of questions. Mark, I have a question for you. This is part of Victoria Littman's question. Can you talk about the role of integration in psychedelic experiences and psychedelic treatment? What is integration and why is it so important?
Absolutely. There are 3 parts of a successful psychedelic journey. Is preparation, where people are perhaps medically screened, psychologically screened, where they may begin to show a commitment in changed behavior or even to change their diet. And at that point of time, they'll set an intention. In the middle, you have the administration phase, which can look a number of different ways depending on where it's given. If it's given in a medical environment, if it's given in a ceremonial environment, or perhaps for people that are doing it on their own, but then it's administered. And then after that, the most important part, which is integration, which is where people try to make sense of the what goes on during their non-ordinary states of consciousness. And why this is so important is that we're finding that it's during those states where these things happen that we're not quite sure if it was real or if it wasn't, but it was really somehow impactful to us personally, right? We found that those are where the deepest healing comes. So once people have made sense of what's happened, then it becomes very important to take that message, to take those feelings and that shown action, and to actually incorporate it into your life.
Thank you. That was very helpful. So we have another question from the audience about the efficacy rates of psychedelics as compared to other treatments like psychotherapy or methadone, Suboxone. Do any of our panelists have any research or knowledge of that?
We don't have the research. I mean, in order to do that, you have to have a head-to-head comparison. And we simply don't have it. We don't have it yet for anything, but the psilocybin at least is coursing ahead in phase 2 clinical trials. And when you get to a phase 3, of course, you have a much larger sample set. And there you'll be able to look at the benefits of classic antidepressants versus psilocybin therapy and the window of efficacy. Because one of the things about psychedelics that we haven't mentioned is that they have a window. They open a window of efficacy. And why is that? Because they're what we call psychoplastogens. They're turning on plasticity in the brain. And that's what Mark is describing in terms of the integration, is that, neurons that fire together, wire together. So again, thinking about, I think a point that was you raised about combining these molecules together. Can we use, many people cannot transition, opioid-dependent patients cannot transition on to naltrexone because even though they go through classic detox, standard medical detox, they still have a post-acute withdrawal and they've got cravings and they just feel terrible. Can ibogaine accelerate that so that we can transition them onto naltrexone? Would the outcomes of combining ibogaine for a detox with naltrexone give us better efficacy data? And those are the types of studies that we need to do.
So I'm going to turn to Mason, but I just want to say a quick note that many people are stable on Suboxone. It's meeting their clinical needs and they're in active recovery. And so people don't necessarily need to transition off of medications like Suboxone when they're stable on those medications. That's a decision between them and their doctor. Okay, Mason, go ahead.
I appreciated the acknowledgement that we don't really have data on comparative efficacy between existing treatments and psychedelics. And that's true of most aspects of psychedelics as treatments. We don't have data. Even those exclusion criteria, I'm not suggesting they should be thrown out or dismissed, but they are highly speculative and they're based on exclusion criteria from clinical trials. So sort of a self-perpetuating exclusion of people because that's how the trials were done. Oftentimes that's done for reasons that are not related to risk, such as wanting to get a good, clean data set. And so people are excluded for various reasons. So just important to note that I think exclusion criteria, even integration, we don't have data on the importance of integration, different types of integration, the extent to which integration is necessary to therapeutic benefit. And I don't mean to minimize the importance of integration. And there are parallels in indigenous communities where they have a lot of community support. And it may be that integration is very helpful. In some cases, may be essential. We just don't have that data. We need more research.
And Mark, I saw your hand raised. Did you want to add to that?
I just think one of the interesting things is that we tell certain people like that have been told that they have certain conditions like bipolar, well, this isn't for you. And I'd like to challenge people. I believe that psychedelics are for just about everyone. And that if you can find the right practitioner and set up the right safety protocols and you have a willing participant, I think that sometimes we're just saying, hey, you guys, you can't do this, when those people, the folks that have been somehow pigeonholed because of a diagnosis, those are the exact people that should be working with psychedelic medicines and should be given the chance. Because from what we're finding out, psychedelic medicines help people with a number of different conditions. With the practitioner, people are able to work through about anything.
Mm-hmm. And that's an area where I will say there is vigorous debate. Deborah, I have a question, I think, for you or Mason. Can you talk about the neural mechanisms involved in psychedelics that might explain the efficacy of psychedelics in treating substance use disorder? And I know this is going to differ based on the psychedelic, but Deborah, you look like you're smiling. Do you want to? That looks like an exciting question for you. I think
it is. Thank you. Yes. So there's a lot of why I'm smiling is because I'm so excited about the new research that's coming forward out of both Stanford University and Johns Hopkins, which is really fundamental information about how the brain works. We have more neurons and neural connections in our brain than there are stars in the Milky Way galaxy. And what we've learned about these molecules, and I'll just limit right now to ibogaine is that ibogaine has an active metabolite, it has a polypharmacology, which means that it's not just acting on modifying one neurotransmitter system and treating one symptom. We've heard there was a little bit of a discussion earlier about the underlying cause of addiction. These molecules seem to be targeting that, and they're doing it by opening up windows of neuroplasticity in the brain. So we know right now the serotonergic psychedelics and ketamine and ibogaine open up a window of neuroplasticity, and they open up in adulthood a period of social reward. This is why they can deal with trauma, traumatic brain injury, and addiction, which we can think of as a brain trauma, because addicting drugs are causing damage to the brain. So that's the idea, that it's actually turning on, the brain has a phenomenal way to heal itself. And think about early recovery when people do transition off of hard drugs and alcohol, that the brain, if this is turning on healing, it's turning on healing in the brain that can help reset not only the neuroplasticity and open that, which is important for cognitive behavioral therapies, which of course what psychedelic integration is, but also that it's giving us a reset, a neurochemical reset, which is why these drugs can be very powerful and transformative.
Thank you. Mason, do you want to add to that?
Yeah, I think again, when it comes to neurochemical mechanisms, we just don't know. We can, there are some theories in early stages. What I find most fascinating is the narrative reports of people who have consumed psychedelics and reported long periods of abstinence from alcohol, for example, or cocaine. And they often report that the drug gave them a sort of insight, a different perspective on their relationship with the substance. They no longer, I recall one example where someone said that I suddenly felt, this is probably Lotsoff, I believe, who said this, that he suddenly saw his relationship with heroin as one that was killing him, and he did not want to die. And it gives them actionable insights, or appears to. That's not a neurochemical explanation, but it's still quite interesting.
I would say it's all neurochemistry, doctor. I would disagree with you on that. And the other thing,
no, it is neurochemistry. We just don't know
it's all neurochemistry.
What it is.
Yeah, it's all neurochemistry. Again, neurons that fire together, wire together. And, if you have the way Mark elegantly described in terms of his own journey, personal journey, is that, we have resilience, and these molecules do give us resilience. And is there a neurochemical reset that goes with that? Yeah, it probably is. And the other thing I'd like to point out is, even with Mr. Lotsoff, who I knew, you're going through opioid withdrawals, you're sick. And the fact that this drug can actually block the symptoms of opioid withdrawal is a physiological response. So I think there's a lot of, we do know, I would disagree a little bit and say that, yes, do you need the trip to reach the destination? Clearly, the ability to think straight and to kind of rewrite your own personal narrative is very much part of the therapeutic efficacy, but don't diminish the fact that these drugs are causing profound changes in the brain. And I think that the data that are coming from Stanford, which we hopefully will see, some of it has been published already, demonstrates that there's cognition enhancement, that there's changes in depression rating scores, and indeed there's functional MRI and other functional imaging studies that are going to show real biomarkers of efficacy. So I'm excited about that.
Mason, any response to that?
Yeah, clearly I wasn't saying that there's no underlying biochemical basis. We just don't know what it is. I think it's a safe assumption that that's the case, unless you believe, it's a spiritual, non-physical mechanism, which could be. And I want to point out that how it's Howard, right? Lossoff. He's typically credited with discovering ibogaine as a treatment for addiction. I would say that was the African Babongo people and other communities there.
So I don't know if there's an answer to this, but what would you say is the psychedelic that has the most research support as a treatment for substance use disorder, if you had to pick one? That's for any of you.
Psilocybin.
Do you agree with that, Deborah and Mason, or would you take a different approach?
It depends on the substance. I think that ibogaine is probably more effective for patients that have opioid use disorder. I don't think we have, again, we don't have the head-to-head comparison of it. So right now it's anecdotal. And we know that data are not the plural of anecdote. So until we look at this, and patients, you can't use psilocybin as a detox for opioid withdrawal syndrome, right? There's no evidence of that out there. So it depends, there are different stages of transitioning off of drugs, and then what's going to work best for relapse prevention, for example. Let's level the field and talk about relapse prevention. I mean, we just simply don't know. We simply don't know.
Well, there are a lot of studies that are out right now for psilocybin in particular, right? So you have the Johns Hopkins smoking cessation study. You have the NYU alcohol use disorder study. Now you're gonna, if this spring, Peter Hendricks at the University of Alabama Birmingham is going to release his study on psilocybin and cocaine use disorder. And that's all very encouraging. And, when it comes to ibogaine, right, people still have to be detoxed beforehand. So they have to go through a lot of the same things first. And if I remember correctly, there's about to be a study with psilocybin and opiate use disorder. They compared they'd used LSD at one point in time to help people to break free of opiates. And then when they look at some of those other studies, they say that this is a potential. And the thing about psilocybin is that it's available now. There are people that are able to utilize this in certain states, whether it's under, say, a supported adult use model or where it's just decriminalized, and it's making a difference now. And when I say this, I'm not trying to detract anything from ibogaine or from iboga. It's very important. And especially with iboga, it's sacred. You have practitioners, providers that are helping people right now in the United States with this medicine.
In the context of relapse prevention. So for the listeners, I think that the studies, the Bogenschutz study and the other studies that are out there need to be viewed in the context that they are very early stage. They're small cohorts. They're not blinded. They're not randomized clinical trials. And until we get to RCT, until we can get to randomized clinical trials, we're not going to have that evidence-based information. In terms of harm reduction and self-help movement, what Mark is describing is for many patients, and all of us are hearing this, is that patients are endorsing these molecules as beneficial to them. And I think, again, I think Stephanie was the one who said that just like right now with approved medications for addiction therapy, addiction is a complicated disorder. And there are people that come to use drugs and alcohol as self-medication. It's not just bad behavior. People find themselves it's an acquired disease, right? And if you never use drugs or alcohol, you're not going to get addicted to them. So it's an acquired disease, but many people have underlying risk. And I think that the more we learn about this and the more that the society and the law allows us to study and test these molecules, that the better information will be available to us.
So what do you think about the prescribing programs? You have a virtual prescriber and people can use substances within the psychedelics within the privacy of their own homes. Like, for example, there's a company that prescribes ketamine, and then people are at home. They have someone who virtually supervises a journey, and you can get this all online. What do you think about that? I saw Mark shaking his head.
As a person in recovery, and a coach, I think that there's a lot of concern about ketamine being prescribed telephonically, especially, right? It's something that's being done now. And, when I say this, I want people to know, like, I'm a truth teller, but I also say this with a very gentle heart. I don't mean to be judgmental. I really don't. But what ends up happening is with each different provider, they give prescribe people troches, usually by mail, which are like lozenges that they put into their mouth. And unfortunately, there is no standard. So like from one provider to another, it may be completely different. Some you have to swish in your mouth a few times. Other times you have to swallow, and that becomes very confusing to people, especially when you have all the different platforms. In addition, that can also be confusing to people in early recovery who see this as something that they can go to as an antidepressant without realizing, look, there's going to be a lot more that has to go into this, both as a personal commitment, knowing the medicine, perhaps having somebody there to help them or to supervise them past what they do online. And I think that with all these psychedelic medicines, I think that they should be available, but I also think that it's somehow concerning when it's not face to face. I think that really takes away from the healing potential, and I think that there's some risk that goes along with that. You know, but that's just my opinion. I could very well be wrong.
I agree with Mark on
Do
that.
you want to add to that? Go ahead, Deborah.
I agree with Mark. I think he answered it well.
Yeah. Mason, do you have any comments on that?
I mean, I respect that. I think I have a slightly different take on it. Generally speaking, we've been far too restrictive of telehealth prescribing of controlled substances. There's sort of a brief respite from that right now that could be extended, and I think it should be. I think we've learned from some cases of opioid medication-assisted treatment that restricting things too much and requiring too many hurdles for people to jump through can decrease accessibility. So I think I err a bit more on the side of keeping these options open for people, and for people with disabilities, people in rural areas.
So what do you think about the advertisement of, these at-home ketamine programs on, Facebook, for example?
It's a FDA-approved medication. It's not illegal. It's being prescribed by licensed healthcare providers. And I say, if there are bad actors, go after them individually, but don't, throw the baby out with the bathwater just because, like any field of medicine, there are some bad actors.
Okay, that's one perspective. Yeah, and I would say that I think it's important to remember that people seeking any of these treatments are often in tremendous pain and
Yeah.
suffering and feeling very sad and depressed and hopeless. And so there's, of course, no judgment for anyone who's pursuing, even at-home treatment.
It takes courage. It takes courage. And there's a particular statement that was made some time back that when people sit with mushrooms, 5 grams or more with their eyes closed in a dark room, that they've taken a heroic dose, that they've done something heroic. And what I'd like to say is that every single person who has the courage and the heart to work with psychedelic medicines is a hero and should be recognized, no matter what it is, no matter how small, just as long as it's impacted their lives in some way.
Mhm. Okay. We have another question from the audience. Could one of you comment on the natural resonance between the principles embedded within the 12 steps and the application of psychedelics to treat substance use disorders? They would seem to be quite a good fit as the central mechanisms central mechanisms of change within the 12 steps, which are both spiritual and psychological. Any thoughts on that?
No.
Go ahead, Mark.
Absolutely. Yeah, very, very important question. Believe it or not, and while it may not be everyone's cup of tea, there is a support program out there right now that works with psychedelic medicines and with people that are trying to find a new way to live. It's called Psychedelics in Recovery. And the interesting thing, from my own personal experience, and you can see my books back here. I spent many years going to meetings, doing step work, carrying the message, and yet it always felt like there was something that was missing there. Like there was just a word missing out of every sentence, and I couldn't get it. But once I began working with psychedelic medicines, all of a sudden things change. Now, I've got something for you, right? In the context of the first 3 steps, very much like psychedelic medicines, right? In the first step, people say, I can't. They have some sort of problem that seems to be insurmountable that they can't get by, and that it makes their life unmanageable. So they come to this admission, this foundational, honest admission that they can't do something. In the second step, we use this with plant medicines, right? They say that the plant can. In the second step, normally people are admit that they haven't been able to do it on their own, and they're looking for some sort of outside help. And while for a while we used a higher power, in this case we put the psychedelic medicine there. And finally, in the third step, people say that the plant can, and they actually work with the medicine. So rather than even intellectualizing it, it's an actual process. And it's all very synergistic, and psychedelic medicines will definitely be something that blends in with all of these other modalities. And the 12 steps are most certainly one of them. And hats off to Psychedelics and Recovery for their great work.
Thank you, Mark. And I also want to give a plug for Smart Recovery, which is a science-based peer support group. We have a lot of different options. I know we often talk about AA and NA, but there's a lot of different options for peer support recovery. Okay, so I think I have a question for the panel. What do you think is being missed in this discussion of psychedelics and substance use disorder? What do you think people are not focusing enough on, or what's being left out of the conversation? And I'll start with Mason.
The role that Indigenous communities have played in discovering and developing these practices. And, you know, I wish we had more time to talk about it in greater detail. I think if it's mentioned at all, it's mentioned.
What do you think? A couple minutes. Feel free to educate the audience.
I think there are efforts sometimes to make symbolic gestures by companies that, you know, pledge a certain amount of their profits, perhaps, or maybe to invest in those communities. But I think we need to have a much deeper conversation about that. Colorado, for example, as a state, is making legal changes about mescaline, which is used in sacred ceremonies by Native Americans and people throughout Mexico. And there really was no, you know, discussion or meaningful engagement with those communities prior to doing so. So there needs to be more upfront dialogue, you know, not just symbolic gestures, but actual meaningful interaction with these communities. A lot of the ibogaine, for example, is exported illegally from Africa. So if it's going to be used in the United States, where is it going to come from? And then I mentioned the great diversity of people in Africa who use iboga. Can you get consent from one of those communities and then say that you got consent from the people that use ibogaine in Africa? I think it's very complex and nuanced conversations that need to be had about this.
Thank you for that. Deborah, what about you? What do you think is being left out of this discussion?
Well, just to follow up on that statement, I mean, not to diminish the reciprocity for Gabon and the sacred iboga roots, but you can do semi-synthetic routes to ibogaine. We did it. You can make GMP multi-kilogram quantities of ibogaine that's ready to be used in humans. There's an effort to go fully synthetic routes to these molecules. What I want to say is research, research, and research. We need to pick up the pace of regulatory approved research studies in the United States to make these molecules approved medicines available to people in rural communities, in the inner cities, to those that are suffering the most. Society.
We have about a minute left. So I'm going to go to the final.
Stop.
To Mark.
Pick it up. Pick up the
Mark,
pace.
Mark, very quickly, what do you think is being left out?
There's a lot of support that's necessary for people after they work with psychedelic medicines. And that's going to extend past working with therapists. So that's going to mean for a lot of new coaches. It's going to also mean for places like recovery residences, or what people call transitional houses, that are psychedelic medicine friendly, that can help to house people after their experience. You know, I think that's something that we also fail to remind people is this is hard work.
Yeah.
especially when you're shown the deepest, darkest part of yourselves, when you speak to people that have died, or when you relive past traumas during psychedelic experiences. That's very hard.
I think it's a
And
really good point. And just to wrap things up a little bit, I think what everyone has said is substance use disorder is a very difficult and challenging illness, and psychedelics provide a potential pathway to ease some of that pain. And there's a lot of nuances to this discussion, and I really appreciate Deborah, Mark, and Mason shedding light on just a piece of some of these nuances, and also just really wonderful questions from the audience. And I want to thank the panelists and also Petrie-Flom and the Center for Law, Brain, and Behavior for sponsoring this really important event. And thank you again for tuning in and listening to our wonderful contributors.
thank you.
Thank you.
Thank you.